So we're talking about the Cook Hemospray today, and the basically this is more informational than demonstration. So we're going to talk about the how it works and kind of the Q&A portion. So Hemospray, the way it actually works, it adheres to the liquid in blood, or dehydrates it, we'll say, and each tiny particle attaches to one another, and it actually expands about 30 times its actual size and will develop or form a mechanical barrier to stop this bleeding. So the ideal bleed that we're looking at is a cancerous lesion. So once again, the IFU states that this is a non-variceal bleed. So a cancerous lesion that does not want to be touched or poked by any other devices. The Hemospray will actually act kind of like a fire hose and spray, so it does not have contact with the actual lesion. And once it comes in contact with the lesion, it attaches and dehydrates the liquid. So looking at the actual label first, this is one of the most important components. This is a Hemo 7, meaning 7 French, and the 7 French will go on to a minimum 2.8 millimeter channel of a scope. So that doesn't mean that it can't go on to a larger scope. That's just the minimum size. The Hemo 10 will demonstrate a larger channel size. So make sure that you evaluate which one that you grab, and it'll show the minimum channel size. First step that we're looking at, we'll just kind of go through the lab card, is go ahead and tighten the lower portion of the handle. And what that's allowing you to do is to charge the handle. And it's basically engaging the CO2 cartridge and moving it up and allowing it to break a seal, so it is now available and charged. The one portion we do not have, but may label later, right between the preparation and step 1, is to detach suction. It's extremely important to detach the suction so that you don't get any moisture into the channel of the scope. The next step is going ahead and using a 50 or 60 cc syringe of air and using some, probably 4 to 6 aggressive thrusts until you do not see moisture coming out of the distal end of the scope any longer. Then the step 2 is going ahead and covering the distal end or the proximal end of the catheter, making sure that this will be kind of a method so no moisture will come in the distal end of the catheter once it's sent down the scope. As we move down through here, we're going to go ahead and we're going to attach the catheter onto the handle and ready for deployment. We'll engage or turn it on at the very end of the barrel, and once the physician tells you to spray, go ahead and activate the, I'm going to grab the handle, activate the handle by using a count method of 1/1000, 2/1000. And the reason that we have that time frame is we have 20 grams of material inside of the cap here. This handle will deploy 1 gram of material at a time. So each time that you hold this in, 1/1000, 2/1000, the handle will deploy 1 gram of material while the CO2 engages. So if I hold it in for a long period of time, the CO2 will continue to run. However, it's not going to push out any more CO2 or any more material. If you do run into a situation where the material is kind of sputtering out, it's not coming out nice and fluid, it might be because in the trough here it's getting kind of bunched up. So you might want to tap it, shake it, do anything to move the material so that it doesn't get in a clumped up material. Let's see. The next step that we're going to just look and be extremely liberal when you're spraying this. This container holds 20 grams, and typically you probably won't use more than 8 to 10 grams. However, if you have a question if it's still bleeding, keep spraying. And it's going to look like a complete snowstorm. It's going to be all white out, but that's what you're looking for. This is inert material, so typically within 72 hours it'll slough off and pass through your system. basically the last steps. When you are finished, you can go ahead and turn off your stopcock, and if the scope is removed from the patient, the procedure is done, you can go ahead and release the CO2 cartridge and dispose of it properly based on your hospital policies.
Okay. And then how about the 10 French? What would happen if you tried to use the 10 French in a non-therapeutic scope?
So if you try to use a 10 French, it just would not go down the channel. So the 10 French is a larger diameter, and if you try to put a 10 French, which would be recommended for like a therapeutic or colonoscope, down a EGD scope, it's just not going to fit.
Okay.
So we're trying to push one of these in.
It'll be really tight.
Very tight and lots of resistance. Like from here, I can't physically push any further. Whereas the 7 French, I can push all the way through.
And just for clarification, for the sake of training, we had a 7 French and a 10 French in this one container, but in reality, you would have 2 7 French catheters or 2 10 French if it was the 10 French pack that you grabbed.